Welcome and good evening. My name is Alex Bird, and with Caleb McDaniel, I am co-chair of the Rice University Task Force on Slavery, Segregation, and Racial Injustice. The task force has three main charges, none more important than its second, concerning the organization of public programming in support of frank and honest discussion around issues on which the task force is focused. Thus, it is my great pleasure this evening to welcome you to our first webinar of the new academic year, Segregated Medicine, Racial Politics and the Shaping of American Healthcare. We are fortunate to have two inspired, inspiring, and accomplished members of the Rice community at the helm of tonight's event. Nana Mensah-Bonsu is co-president of the university's DAWA Pre-Health Society, a leader in the Rice University African Students Association, and an emerging scholar of health disparities. Kirsten Ostherr is chair of the Rice University English Department, founding director of the university's program in medical humanities, and Gladys Louise Fox professor in the School of Humanities. I'm happy to turn things over to them now, and I'm very excited about the next hour.
Hi, everyone. As Dr. Bird said, we wanted to thank you all for spending your evening with us and being here today. As Dr. Bird said, I am Nana Mensah-Bonsu. I'm a junior in studying psychology here at Rice, and I am also co-president of DAWA Pre-Health Society for Underrepresented Minorities, which is why I think it's really important that I learn what I can from this talk and we all learn as well. Right now, I'm extremely excited to be here tonight and introduce these two wonderful individuals, Dr. Eseosa Ighodaro and Dr. Ezelle Sanford. First, I would like to introduce Dr. Ezelle Sanford. Okay. So Dr. Ezelle Sanford III is an assistant professor of history at Carnegie Mellon University and visiting assistant professor at Johns Hopkins University. His scholarships sit at the intersection of African-American, medical, and urban histories. He is particularly interested in histories of race, science, and medicine from the 19th century to the present, and he is currently working on a book project called Segregated Medicine: How Racial Politics Shaped American Healthcare, which utilizes the case of St. Louis's Homer G. Phillips Hospital, America's largest segregated hospital in the mid-20th century, to trace how the logic and legacy of racial segregation had established structures of healthcare inequality that persist to this day. His work has been featured in popular and academic publications and has received several fellowships and awards. Dr. Sanford, you can now discuss your thoughts on segregated medicine.
Hey, all right, can everyone hear me okay? Am I good? Yeah, I'm good, okay. All right, wonderful. Good evening, everybody, and thank you so much, Nina, for your introduction. I also want to express my sincere thanks to Dr. Alex Bird, and of course, Rice University's Task Force on Slavery, Segregation, and Racial Injustice for inviting me to briefly share my work today. And I should say that in my work at the Penn Medicine and the Afterlives of Slavery Project, before coming to Carnegie Mellon, in the program on Race Science Society, which is directed by Dorothy Roberts at the University of Pennsylvania, we look to Rice's task force as a peer effort to engage with hard institutional histories and their contributions to present-day inequity. So it is a pleasure to be here with you all. Today, I'm going to share a brief outline of my book project, which is titled Segregated Medicine: How Racial Politics Shaped American Healthcare, which uses the important historical case of St. Louis's Homer G. Phillips Hospital to understand the broad impact of racial segregation in medicine and African Americans' role in the shaping and evolution of American healthcare across the 20th century. My book argues that across the 20th century, African Americans used the contested site of health and healthcare to engage in social, political, and economic struggles for equality and full citizenship. Now, before I jump in, I think it's important to first note that our healthcare system, especially its network of acute care hospitals as it currently stands, developed and matured in the Jim Crow era. And as the health management scholar David Barton Smith notes, quote, the underlying social attitudes, unquote, about race and power were important in the shaping and the distribution of health resources in the United States. And we are, of course, still contending with the structural inequities embedded within American healthcare today. And I hope that our conversation will take us to discuss that. So segregated medicine posed a problem for African Americans. Where would they obtain care? How would they train Black health professionals? And as hospitals became the locus of care in the early 20th century, African Americans were often barred from exclusively white hospitals. This was, of course, extremely dangerous, especially in the case of emergencies, where segregation could be deadly if a white hospital refused to admit a Black patient. And there were many such cases, some of which were outlined in the 1952 publication of Alfred Manu's The Untouchables, which was a pamphlet that described many of these cases where African Americans were severely injured or died after being refused admission to a white hospital. And in that pamphlet, Manu talks about the case of Juliet Dirico, who was the Dean of Women at Fisk University, who died in 1931. She was injured in a car crash in Georgia, and the nearby white hospital had no more available hospital beds for her care. Charles Drew, then the noted inventor of blood storage technologies, which led to blood banking, died in 1950 after a car crash in North Carolina. Now, African Americans widely believe that he suffered a similar fate as Juliet Dirico several decades earlier. But these rumors, as the historian Spencer Love has demonstrated, were untrue. But yet they spoke to a wider reality of the perils of segregated medicine. If Black people were admitted to hospitals at all, they could be treated in, quote, colored wards in hospital basements, attics, and adjacent auxiliary buildings. Often these were under-resourced, under-financed, and weren't comparable to the facilities available to white patients. And this was the case at St. Louis's Barnes Hospital, which is now the Associated Teaching Hospital of Washington University in St. Louis, one of the premier medical schools in the United States. And yet African Americans took it upon themselves to establish hospitals and medical schools in what historian Vanessa Gamble termed the Black hospital movement from 1920 to 1945. And these Black hospitals were largely owned and administered by African Americans. They were a source of pride and easily accessible and deeply integrated into African American communities in which they served. Now, Homer G. Phillips Hospital was a part of this broader movement in the early 20th century. It was a municipal teaching hospital established by the city of St. Louis. But African Americans lobbied the municipal government in the 1920s to build a fully separate and autonomous hospital to protect indigent Black patients from insensitive care and fears of experimentation, and also to train Black health professionals. And so I use this particular hospital to tell a national story, one where I can easily identify and trace in granular detail African American actors as they navigated the tricky terrain of racial segregation in medicine. And from this fixed perspective, I analyzed how these actors navigated shifting federal policy, from the financing of segregated hospital construction through New Deal policies and the 1940s Hospital Construction and Modernization Act, to the funding of Medicare and the state-run program Medicaid as American healthcare desegregated in the 1950s and 60s. I trace how these institutions, in the wake of a successful medical civil rights movement, began to close, move, or merge with other institutions. And though hospitals were effectively desegregated, incentivized by federal funds, to many grassroots activists and health professionals, the dream of equitable treatment and access to care remained elusive even in this sort of post-civil rights moment. And so I try to explain this in my book, Segregated Medicine. And so in many ways, Homer G. Phillips Hospital was unique, St. Louis is a border city and a border state. It's an important site in the history of American race relations. It's what historian Walter Johnson deemed the broken heart of America. It was a terminus for some and a throughway for others who were engaged in the Great Migration from the South to the North and West. It was a site of important court cases where African Americans attempted to expand their freedoms in place in American society, from the Dred Scott decision to the Lloyd Gaines decision in the 1930s about professional training in terms of law schools, to the Shelley v. Kramer decision, which ruled race restrictive covenants unenforceable. It was also the site of anti-Black racial violence, especially the 1917 East St. Louis race massacre, which impacted hundreds of Black East St. Louisans, not to mention the hundreds that were killed. And so when Homer G. Opened in 1937, a Black attorney, David Grant, called it, quote, the biggest Jim Crow institution in the world. And though African Americans established their own health institutions as a way to resist segregation in medicine, it remained nonetheless a social and political problem. Now, upon Grant's recommendation, and this is one of the many ironies throughout my work, the hospital bore the name of the African American attorney, Homer Garland Phillips, who was based in St. Louis and who was publicly assassinated years earlier before the hospital's opening in 1931. Now, Attorney Phillips adamantly opposed any form of segregation, including, at least initially, this particular hospital. This is another one of those ironies that appears in my work. And it was an uneasy concession for both white municipal leaders and African Americans. The white leaders were committed to the project of racial segregation and constrained by the law. And African Americans, under the constraints of Jim Crow, saw complete separation and autonomy as perhaps the best way to address Black health needs at the time. In many other ways, however, Homer G. Phillips' story maps into a broader history of segregated hospital care and how Black and white actors mobilized racial politics. And I define that as the use of racial identity to conserve and distribute power and resources. And as I mentioned, Black St. Louis is politically organized in the face of racial violence and hardening segregation policies and practices to secure this hospital, Homer G. Phillips Hospital. And its opening in 1937, its operation, and eventual closure in 1979 served as a political primer for generations of Black St. Louisans who were engaged in the long struggle for Black freedom. Furthermore, Homer G. was unique for its prolific production of Black health practitioners in the Jim Crow era. The hospital was large. It had anywhere from 600 to 800 beds throughout its history, and was among the largest general hospitals in the United States. Now, in terms of segregation and medical education, I think it's important for us to speak briefly about the legacy of Abraham Flexner's 1910 evaluation of medical education in the United States that constrained who could be a doctor and where they trained. And many of the Black proprietary medical schools that were established in the late 19th century, particularly in the South of the United States, closed in the wake of this report, leaving only Howard University School of Medicine and Meharry Medical College to train the bulk of undergraduate medical trainees. Flexner's legacy is evident in the demography of today's profession, one that remains largely white and male. But as a teaching hospital, Homer G. Phillips offered internship opportunities, what became known as the required 5th year of medical school. It also offered residency programs, notably its 5-year surgical residency program for graduate medical trainees. It was one of only 5 institutions to offer such opportunities to Black doctors to pursue specialty care in the United States. Now, segregated medicine was a part of a broad movement for Black freedom in the mid-20th century. And leaders like the National Medical Association's W. Montague Cobb characterized segregated healthcare as the, quote, Negro medical ghetto. Physicians like Hubert Eaton and George Simpkins, both of whom resided in North Carolina, practiced in North Carolina, sued health institutions that segregated patient care and discriminated against Black health professionals. Both were prevented from practicing in white hospitals in North Carolina. In 1963, George Simpkins, who was a dentist, won a suit against Moses Cone Hospital, ushering in a new era for American healthcare, and that was desegregation. In 1964, the Civil Rights Act mandated that all hospitals desegregated, and it was further incentivized with Medicare and Medicaid funding. Now, there were some Southern hospitals that refused to desegregate and thus could not participate in these newfound programs, insurance programs. Some hospitals desegregated earlier, like St. Louis's municipal hospitals. This included Homer G. Phillips. St. Louis's municipal hospitals desegregated in 1955. Johns Hopkins Hospital also began desegregating services in the 1950s. And though hospital desegregation was largely a success, in the words of David Barton Smith, hospitals desegregated quickly and quietly, almost overnight. This was not the case for public schools following Brown, for example, and I hope we can talk a little bit more about segregation and desegregation in schools and hospitals. But by the 1970s, however, it became clear to Black health practitioners and grassroots activists that desegregation did not necessarily stop racial discrimination, nor did it bring about entirely equitable treatment within hospitals. And these, of course, are also issues that activists are still engaged in today, and issues that we have seen, particularly in the context of the recent, still ongoing COVID-19 pandemic. Additionally, Black serving hospitals began to close. Again, they began to move and they began to merge with other health systems. Such was the case at Homer G. Phillips Hospital, which closed in 1979. As St. Louis, like many other cities, got out of the hospital business. Healthcare, especially in the 1970s, was growing more expensive amid inflation. Administrators could no longer justify duplicating and segregating health services. In many ways, segregation itself became too expensive to maintain and impractical. And in St. Louis, activists waged a multi-decade-long battle with the city to preserve Homer G. Phillips Hospital. You might ask yourself, well, why? Why would African Americans mobilize over multiple decades to preserve a formerly segregated institution? Well, activists like nurse Zenobia Thompson, for example, who grew up in the neighborhood where Homer G. Phillips Hospital was located, trained as a nurse at that institution, and has been a long time community health activist. She recognized in the 1970s that Black serving institutions were closing across the United States. And these Black St. Louisans demanded more hospital care in the latter half of the 20th century, not less, which is exactly what was happening in the wake of hospital desegregation. They demanded an expansion of public hospital facilities as the number of Black hospitals began to dwindle in the new economy of American care. Today, the neighborhood where Homer G. Phillips Hospital operated is now designated as a medically underserved community. And I will just conclude with this brief observation, which is that in the Jim Crow era, Black St. Louisans survived and thrived by making a place for themselves, in the words of historian Vanessa Gamble. And yet, amid the political, social, and economic realignment of American care in the 1960s and the collapse of historically Black serving institutions, it created new kinds of inequities along also old societal fault lines, especially concerning access to care. And so There's much more that I can say about Homer G. Phillips and about the network of segregated hospitals, and I hope we can speak about them in our conversation. But I'll stop here for now. So thank you all so much for taking the time.
Thank you for the insight, Dr. Sanford, and I hope we'll be hearing more from you in the Q&A a little later. Now I'd like to formally introduce Dr. Ighodaro. Dr. Eseosa Ighodaro graduated with honors and summa cum laude with a Bachelor of Science in Biology and minors in Chemistry and French at the University of Kentucky. After graduation, she matriculated into the combined MD Ph.D. program at the University of Kentucky College of Medicine, where she was the first African-American woman to complete the program. During her training, she has published numerous articles on dementia, cerebral vascular disease, and health inequalities within African Americans, and her recent publications have been featured in Nature and Nature Medicine. Moreover, she has received numerous awards for her activism work on campus and within the community. Currently, she is a neurologist, neuroscientist, and a health advocate at the Mayo Clinic in Rochester, Minnesota, and her current research interest focuses on understanding the role of racism within neurological disorders. Dr. Ighodaro, the floor is yours to now talk about segregated medicine.
Thank you. Thank you so much for that phenomenal introduction. And I want to thank Rice University for inviting me to be able to participate in this very much needed conversation. So what I'll do now is I will share my screen. So I'm basically going to be talking about my observations of medical racism through my beautiful dark brown eyes. So as Nana said, I'm currently a neurologist at Mayo Clinic. I'm a neuroscientist and health disparities researcher. I've been in the medical field from as a medical student, as a researcher, and now as a resident for the last 10 years. So there's a lot of things that I have seen and experienced throughout my tenureship as a physician scientist. Disclaimer, comments that I will share today are my opinions and my opinions only. I am not representing or speaking on behalf of my current employer, Mayo Clinic. So with that, we'll just get into my observations. One thing that COVID-19 has really done is it really highlighted medical disparities that are facing marginalized and underserved communities. One of the well-known horrible complications and basically just major evidence of medical racism has to do with Dr. Susan Moore. So for those of you guys who don't know her story, she was a Black female physician who had been practicing medicine for 20 plus years, and she started to develop symptoms of COVID. She went to her local hospital and she went to the ED talking about shortness of breath and pain, and she was concerned that she had COVID-19, and she was made to feel that she was a drug seeking, that she didn't know what she was talking about. Mind you, she was a physician, she had an MD, and she was experiencing racism from her own colleagues. Because of that, she was later she didn't get the appropriate treatment that she felt that she needed. And because of COVID-19 restrictions, there were a lot of limitations in who could visit individuals in the hospital. So while she was experiencing shortness of breath, while she was wearing a nasal cannula because her oxygen sats were desaturating, her last resort was to fight for her life. So she goes on Facebook, she goes on Twitter, and she is basically documenting her medical racism that she's experiencing while in the hospital, begging for someone to help her, begging for her to be seen as human, and begging for her to be treated appropriately as other individuals who have COVID-19 are treated. Unfortunately, she gets discharged. She gets sent home. Her symptoms of shortness of breath get worse. She then goes back to the hospital, and now she's intubated because she can't breathe. So she has an artificial machine helping her breathe. And unfortunately, she dies because of COVID-19 complications. And this is not a unique story to her. This spans across hospitals. This spans across decades. Black individuals are not getting the treatment that they need at the hands of the hospital system ever since hospitals became desegregated. So here's another example of a young 9-year-old female who died of COVID-19. Again, she was having symptoms. She went to her local hospital. She was turned away, and then she dies of COVID-19. Had she been white, the story would have been different. And it's not just in COVID-19. The media has really done a phenomenal job in focusing on certain treatments or certain types of medical racism and different other aspects of medicine outside of COVID-19. One thing being pregnancy. It's been well documented in medical literature and mainstream media. Celebrities have Black female celebrities and just Black females have poor outcomes in giving birth compared to their white counterparts. And there's been a really well-known study that talks about if you control for socioeconomic status, for other social determinants of health, you can have a highly educated Black woman give birth. Her outcomes are going to be more poor compared to an uneducated white female. And the question lies in, well, why is that? And as a Black female, I know why it is, but the medical system is having a hard time wrapping their mind around race and racism at the hands of the people who are supposed to be taking care of us. So here's another story where a young Black mother died after treatments for her postpartum depression after giving birth, and the family is demanding answers and answers they still haven't received. Because there's been a lot of attention on, the issues of medical racism, the field now is recognizing, what are the causes? Why is it that Black individuals have poor health outcomes across all areas of medicine, whether it's neurology, whether it's cardiovascular, whether it's COVID-19, whether it's OB-GYN? Black people are dying, and we're dying at the hands of the hospital system. So this paper that came out of Harvard Public Health tries to talk about, well, why is it that this is occurring in OB-GYN? Another topic that's been really well known in the medical literature is that anytime a Black patient goes into the emergency room complaining of pain, we get tagged as drug seeking. You'll have a sickle cell patient so in sickle cell, what happens is you basically, your blood vessels stop feeding oxygen to vital organs. Those organs start to die off, and that's an extremely painful process. So patients that have sickle cells will document it when they go into the hospital. Sickle cell, it unfortunately has a higher incidence in the Black community. So when people who have sickle cell go into the hospital and they have sickle cell and they're complaining of pain, they get targeted as, oh, you're seeking medications, you're seeking drugs, we're not going to give it to you, we're not going to treat you. When in reality, we're undertreating their pain, they're going to lead to more complications and they're going to have poor outcomes because the hospital system is not taking care of their pain management. So there are a few papers talking about this issue and trying to bring attention to it so that we can do better. Here's another paper that tries to figure out why is it that Black individuals are dying at higher rates than other individuals from different racial, socioeconomic status groups. And here's a phenomenal book that I read in graduate school that pretty much changed my outlook. And it kind of answers the question of, well, where did medical racism come from? Because it's not something that just all of a sudden happened. As Dr. Sanford mentioned in his presentation, this is systemic and it's inherent to our culture in America. And the medical system is based out of slavery. A lot of the techniques, a lot of the procedures, a lot of the vaccines and medications that we now use were all developed during slavery on the backs of slaves. And there's just a lot of medical racism, biological racism, and a lot of foundational material that we hold to be true based out of, slavery medical practice. And this book by Harriet Washington does a phenomenal job in really illustrating medical racism from the 18th, 19th century to today. So I encourage you all to take a look at this book and really try to wrap your mind around why is it that we're still having these discussions today, and why is it that Black people are still dying at the hands of the hospital? So these are some of the things that I've noticed. These are some of the things I've noticed that have been published, that I've seen in my practice and in research. So what's my response? What have I done? So what surprises me is that people still don't know that medical racism exists. A lot of individuals I've talked with, like the medical community at large, still has not caught up with this concept of medical racism. So once I heard Dr. Susan Moore's story back in December 2020, I took it upon myself to say, you know what? Hospital administrators, medical associations are not putting out statements. No one is talking about her death. I'm gonna just talk about it. So I decided to do a panel discussion that consisted of 8 to 9 Black female physicians and scientists across the country. And we come and we talk about what her story signifies and what it means and what are we going to do about it. So it's about a 2-hour-long conversation. So I encourage you to take a look at that panel discussion. And because of the positive feedback that I received from this panel discussion, it led me to do more panel discussions. So the second one I did has to do with structural racism in medicine. So in medicine, when we try and talk about racism, we do it in a way that there's people who call themselves experts who are not experts. So unfortunately, there was a really prominent journal that did a podcast talking about structural racism. What is it? Why is it a problem? And what can we do about it? And it was done by 2 white men who were not experts in the field, and they're basically dismissing and gaslighting this concept of structural racism. And the podcast went viral because it was such a horrible, inaccurate, not based in any kind of scientific evidence. And when I listened to the podcast, I was like, I have to do a panel discussion. So myself and 5 or 6 other experts in our field, I got them together. We did this panel discussion to talk about the dangers of misinformation and inaccurate information being perpetuated in these kind of topics and what we can do moving forward. Fortunately, the editor-in-chief at that time is now resigned, and they're looking for more individuals who are experts in the field of race and racism so that this doesn't happen again. Another thing I did, given that there's been a lot of attention on the health disparities in individuals who give, and Black females who are giving birth, I decided to partner with about 6 or 7 of my colleagues in OB-GYN and host another panel discussion so that we can continue to put this out there. Because what happens is we have stories like Dr. Susan Moore that people are reading for about a couple of days, and then the media moves on to something else, the public moves on to something else, and nothing really gets done, said, and gets swept under the rug. And one of my goals is we got to keep talking about these issues, keep putting it out there so that we don't forget. So these are just some of the panel discussions that I've done, but I've also taken it to the next level and started, just giving seminar presentations to individuals like yourself and to communities and academic institutions to talk about these issues. So these are just some of the presentations that I've done across different academic institutions. This one was done at Harvard. This one was done at the University of Kentucky, my alma mater, talking about representation of representation of individuals in clinical research and clinical trials. And this is another presentation that I did as well for one of my neurology groups that really talks about, because in order to eliminate medical racism, there's many solutions, and I hope that we get to talk about some of those solutions in the Q&A, but we have to first bring individuals from diverse backgrounds into the medical practice in the medical field to be able to highlight these issues and make change. So this is what this conversation was about. And I've also started writing papers. So this was the paper that I wrote with Alexander Bird here, who invited me to give this presentation. He was one of the mentors on this project that really just talks about our medical information is based on racist belief, racist ideas, and then what are we going to do to create better, sound scientific protocols so that they're not oppressing Black individuals, but they're helping. So this was the paper that we wrote that just really talks about what are some challenges and considerations we should be thinking about when we're designing clinical trials and clinical studies in dementia, which is one of my fields of expertise. Another thing I was able to do once Dr. Susan Moore's story came out is write call to action pieces in top medical journals. So this is a medical journal. It's been accessed over 2,000 times. And in this paper, we really call the field to empower voices of Black females in science and medicine, and hear our stories and hear what we're doing and what we're seeing in hopes of creating change to make it better for Black patients in the healthcare system. And here's oh, that's a repeat, sorry. This was supposed to be a screenshot of another paper I wrote in Nature that basically talked about that the US is doing a disservice to Black individuals and it needs to change, because if it doesn't, Black people continue to die. So that's pretty much a call to action to the field in another really top journal to let them know, hey, this is not something we can keep talking about. We need to do action steps, because if we keep talking, people are going to keep dying. So that was kind of the point of the paper. So with all that, you know, the big thing now is a call to action. And there's many things that can be done, in my opinion, to help to improve on medical racism. And I look forward to being able to have more discussions in our Q&A about what can we do moving forward now that we know what the issues are. What can we do so that people that have my skin color do not keep dying at the hands of a system that's supposed to be protecting us. So with that, here's my contact information. You can get more information about the work that I'm doing on my website, and feel free to email me at president@zigbay.org, and I look forward to our Q&A session. Thank you.
Thank you so much, Dr. Ighodaro and Dr. Sanford, for your incredibly important and powerful presentations. I'm going to start off the Q&A section with some questions for the panelists, but for all of the audience members, you can use the Q&A tab at the bottom of your screen to post questions, and I will, after we talk for a little while, I will start bringing those to the panelists. So please go ahead and post them anytime, and we really welcome your comments and questions. So I would like to ask both of you a question to start off. In a way, one part is maybe for Dr. Sanford and the other a little more for Dr. Ighodaro, but here's the question. Where do you see segregation or the historical legacy of segregation having the most harmful effects in medicine today? And what do you think is the most under-discussed area where racism occurs in medicine without being addressed? The floor is open for either of you to start us off.
That's a great question. I think the evidence, I think the consequences of segregated medicine initially, when medicine was segregated, you know, a lot of the institutions, the white institutions, had these preconceived notions and concepts and ideas of Black inferiority and all these just bogus thoughts that, oh, Black individuals have a higher threshold for pain, so we can do these medical experimentations. And because medicine was founded during the time in the 18th, 19th century where there was this concept of Black inferiority, we practice these techniques and develop these techniques on Black individuals. And I think that carries over into what's being taught to individuals like me when I'm in medicine. So one concept that I've noticed is this idea of the origin of STDs, right? So when I look at my medical textbooks, the only time I ever see a Black person is in the STI section. I don't see it anywhere else. And that stems back to slavery times where we thought that Black females and Black males are more sexually promiscuous. So I think, I don't know if that answers your question, but the consequences of segregated medicine is what we're seeing today, and what we're seeing now is in our medical education, is in our outcomes. And if we don't deconstruct the medical practice, now this probably sounds radical, but if we don't deconstruct it, we will keep dying.
Yeah, I absolutely agree with everything that Dr. Ighodaro just said. And to put a point on it, I mean, you know, sort of the modern medical profession, you know, sort of grows alongside, the period of enslavement, the expansion of empires, right? colonization, that they're in tandem. So you have doctors on slave ships in the Middle Passage, for example, examining the cargo for fitness, right? Constraining and designing nutrition programs such that one can maintain the human cargo at the least possible cost, right? So I think that it's really important, again, to just put a point on what Dr. Ighodaro just said, that we understand that the history of modern medicine is deeply entrenched in these systems, right? And this is where we begin to get medical knowledge about Black people's bodies and white people's bodies, right? When folks are traveling from Europe to West Africa, and they want to understand, well, why are they dying of yellow fever when the indigenous Africans are not, right? I mean, this is how we begin to get the seeds of understanding sort of race and racial difference at the sort of the biological level through the lens of health, and that is transported to us today, as you correctly pointed out. I think also, though, with the history of segregation, that we have to think about it in a holistic way. That not only does it really dictate, sort of how health institutions are distributed across the United States, and which neighborhood it's located in, which populations that it serves. But we also have to think about segregation and its impact and its legacy on the other social determinants of health, right? When we think about housing, when we think about employment, when we think about where Black people, and if we add the factor of class into working class folks, are where they living, what are the health impacts of that? And I've been doing a lot of thinking about this because I think when we talk about sort of racial, sort of racism in medicine, I often think that we sort of do it in these kind of one-track kind of lanes, right? Are we talking about sort of the tools and practices? Are we talking about sort of the sort of outdated ideas about race that continue to be taught in medicine? And I think that we really have to begin to understand, and I'm sort of working on this now, I hope I can write it up at some point, but understand how, racism, the legacies of segregation, sort of are at multiple points along the, sort of the doctor-patient interaction, right? We have to think about the institutions, as I'm sort of interested in my book project. Where are they located? We have to think about the physician, the practitioner themselves. How are they socialized? Where did they grow up? We have to think about the tools that people use. Are we using sort of automatic risk corrections, for example? Are we using, tools to evaluate health that emerged from the period of slavery, in the case of the spirometer, for example, that Lundy Braun has written about? So I think it's really a sort of a multiplied, interaction of racism at so many different areas, right, that can collide upon themselves in the clinic. And I think that's one of the reasons why racism, inequities embedded in our healthcare have remained so durable, and that they're still with us today, right? This is where my book project is trying to go in terms of sort of evaluating the medical civil rights movement, because it was successful in terms of desegregating hospitals. But as you pointed out, Dr. Ighodaro, I mean, we're still, dealing with Black people being treated in a discriminatory way inside of healthcare clinics. And I'll end on this point, just talk about COVID-19. I want to add another case here too. And that's of a man named David Bell, who was a 30-year-old, in his 30s, St. Louisan Black man, looks like me, right? Who, had COVID pneumonia and went to the emergency room at Barnes Hospital in St. Louis 3 times, attempting to be admitted into the hospital. When his wife came to retrieve him after the 3rd time that he attempted to be admitted into the hospital, he was sitting outside in a wheelchair, and he expired as she was wheeling him out to her car, right? And I had to sort of bring that up because it was such a profound case for me. But to think about Barnes Hospital, another sort of institution that I studied in St. Louis, that itself was segregated, right? That we're still dealing with these kinds of questions about, whether Black people can gain access and admission to a hospital, particularly in this pandemic that we know Black people have felt a significant burden of COVID-19, right? So these issues are still with us, even as we have moved people to the same institutions, right? And so, I do think that it's deeper now. What's more dangerous? I'm not exactly sure, but I just know that in my mind, at least from my perspective, that there's so many different factors that are all kind of working together. And I think we have to begin to, study how these various forms of racism are affecting each other and compounding the effects of one another in the space of the clinic.
And if you will love help writing that book, I'm like, oh, that'd be phenomenal, because I have had these conversations with colleagues, and some of them, well, what's the solution? Some people say, well, we need to remove ourselves from these hospital systems and create our own hospital systems. But then you can make the argument, maybe we desegregated, but we never really desegregated. Like on paper, yeah, I can go to the same hospital as another white person, but I'm getting treated differently. So maybe we haven't fully, desegregated, and that's the problem.
That's where I'm going, because again, it's sort of this nominal desegregation. It happens so quickly, right? I mean, it's such a different case than schools, for example, where there's so much resistance. I mean, even today, schools are still segregated, perhaps more so than they were in the 50s, right? But it's because of, again, the fact that segregation was impractical, right? As healthcare and hospital care is becoming more complicated and also more expensive. I mean, follow the money, right? And so when it becomes expensive to maintain duplicated services, and when the federal government gives people, monies to pay for care through these insurance programs, Medicare and Medicaid, right? Hospitals want that money, and even in the sources, you'll see them, sort of talking about whether to segregate, Medicare and Medicaid patients. I mean, it's so built in. And so I totally agree with you that something didn't happen, right? That we're still sort of searching for in terms of, well, how do we make this right? And I think, one answer is, sort of addressing, hospital care. I think another is, having a holistic, again, understanding of how racial discrimination shapes all aspects of our lives that impact our health.
Wow.
Thank you both so much. It's so clear that it's so deep and it's so wide, it's so pervasive. It's like you can point to really like critical points, but the critical points are everywhere and they're underlying, right? And so this leads me to another question I want to ask you. It's a kind of, it's looking at this from a slightly different perspective. You've both shown so clearly how racism and segregation, the legacy of segregation, are a cause of harm to patients, but also to physicians and clearly to society more broadly. I want to ask, what kinds of innovation and improvements to healthcare do you think we've lost as a society because Black physicians' voices were excluded from mainstream American medicine?
I would say our voices are still excluded. I think if you poll Black physicians, we're at high rates of burning out. And if you sat each of us down and if we weren't afraid to lose our jobs so that we could tell our full story, then I think the community and the public will really understand the trauma that it is to be a Black physician in America, knowing that I am practicing racialized medicine. And this is why I do these talks and this is why I write these papers, because that's my only solution. And so that in itself is, I think, a whole nother presentation. But I think because we are silenced, because we want to keep our jobs, we want to be able to keep caring for the people that we want to care for, we still have issues like medical racism that still exist. And you guys have seen, you've seen the studies, you've seen the publications, you've seen the articles where a Black physician speaks out against their hospital because of discrimination. The next day, they don't have a job.
Yeah, that's such a powerful point. And I think, at least from the historical perspective, and I should say I am not, I am not a medical practitioner, right? I wanted to be back in the day, but I am not. I am, a historian, through and through. But what I have seen in my historical work really is just the ability to be able to empathize, to understand, sort of a patient's, or sort of share some cultural, and social perspectives, right? One of the interesting things about Homer G is that, many of the Black doctors lived in the community, around the hospital. Right. And so they understood, again, sort of where the community is located, what are some of the prevailing issues in the community, what are some of the prevailing health problems in the community, right? And I think this goes not just for Black doctors and Black patients, but for any, sort of groups of people that share identities. I think it's so important that that we pay attention to that. Now, there's a fine line, though. So I don't want to sort of, kind of repeat, Abraham Flexner's call to, train Black doctors so that they can, treat the Black people so that the Black people don't get the white people sick, right? So there is a fine line there. But I do think it's important for folks to, especially for underrepresented populations, to have some, to be conversant at least, and deeply knowledgeable of cultural context. And I think that was lost, again, when hospitals desegregate, but also when they start to privatize. And when hospitals are no longer sort of community assets as they were, in the early 20th century. As David Reisner pointed out, doctors themselves are becoming strangers, right, at the bedside, regardless of who you are, right, and where you obtain care. And I do think that there's a lot that's lost, right, when there's not any sort of shared ground between the practitioner and the patient. And I think that's where a lot of some of these issues, particularly in terms of how one is treated in a decent and respectful way, have become such flashpoints. I mean, especially in the COVID pandemic.
Thank you. All right, I have one question for each of you about your own individual work, and then I'm going to start bringing in the audience. So, Dr. Ighodaro, I want to go back to the comment you made about STDs and medical, like anatomy textbooks. I know that you posted a comment on Twitter, right, that led to a big discussion about this. And I wanted to ask you if you could speak a little bit about that and tell the audience a little, is this an ongoing project that you're going to keep working on? If you could just share that a little with us.
Sure, thanks. So I posted that tweet and it went viral to my surprise. And basically the tweet, I'll paraphrase it, is anytime I see Black individuals is in the STD, STI sections and nowhere else. And then with that tweet, I had a sagittal section of a Black man that illustrated the neuroanatomy of the brain. I've been in medicine for 10 years. I have never seen a Black skin tone individual in any other aspect of medical education textbooks, except for what I've shown. And I think that resonated with a lot of individuals because there are a lot of physicians, and scientists, and trainees, and medical students, and general public who would comment and say, I never knew that this was a problem. You opened my eyes. And I'm like, oh, I just thought everyone knew about this. And what was fascinating is other people from different countries like Nigeria or Ghana or Vietnam or China even commented and said, yeah, I see the exact same thing. So I thought, well, maybe it's just a problem here in the US, predominantly white individuals. Okay, cool, fine. But even in countries where the population is majority Black, brown skin tone, what is still being highlighted as the standard of care, as what we all should be striving toward from a health perspective, is white skin tone. And so that was very eye-opening to hear those comments as well. So that led one thing to another. I had a lot of neuroanatomists email me, wanted to collaborate, and I'm working with my current institute institution right now to work toward trying to improve on the medical illustrations that get put out in patient education and medical textbooks and, you know, across the country and across the globe. But it's part of the problem, right? So, and like Dr. Sanford said, is we have to deconstruct healthcare. We have to really deconstruct medical racism, because it's not just when a Black patient goes into the emergency room. It doesn't stop there. It doesn't stop at when I, you know, am called, well, I'm not called doctor because no one assumes I'm the doctor, let alone a scientist. It doesn't stop at the medical textbooks. It's just multifaceted. Until we can fully understand and break down medical racism, I think it will continue to always be a problem. So I'm attacking it from multiple ends. And I hope that, you know, with continuing to speak out, working with individuals, that all of us can come together and start attacking it from other ends so that we can start to, you know, decrease, you know, medical racism.
That's such an important project and so overdue. Thank you. Dr. Sanford, I wanted to ask you, I read on, I think maybe on your website, that in addition to the historical research, the archival research you're doing, that you've started or you're going to start an oral history project.
Yes.
Related to people who worked at or also maybe were patients at the hospital. Can you tell us a little bit about that?
Yeah, that's a wonderful question. Thank you so much. So actually, I did the oral history project in conjunction with my dissertation research while I was in St. Louis, and you know, I should take a step back and say that you know, while I was doing archival research, I mean, I really saw my year and a half in St. Louis as really being ethnographic in a way, because the legacy of Homer G. Phillips is still alive and well. I mean, even today, you know, and we can talk a little bit more about kind of the current iteration of debates about Homer G. Phillips in St. Louis today. But even for folks who, you know, were born after, you know, the institution closed down, I mean, you know, they know about it. That it's such a sort of a powerful kind of cultural relic. But yeah, I wanted to, you know, interview folks who had touched the hospital, who had worked in the hospital. I even interviewed a former mayor, Vincent Shamel, who presided over the hospitals, you know, or sort of once the hospital closed, you know, he was actually elected in part because he promised to reopen the hospital. And so I wanted to sort of get, you know, sort of access some of these memories, right, from folks that weren't yet represented, you know, in the archive. This is one of the problems that I encountered, especially when you're working on recent history, because often that history hasn't quite made it. Those sources haven't quite made it to the archive as of yet. And so I've done 5 interviews with folks who were, again, community activists, health professionals, municipal leaders. I wasn't able to interview any patients, in part because, you know, it gets a little dicey in terms of HIPAA laws. I wasn't able to look at medical records, for example, in part because they were lost. They were also, you know, just recently rediscovered, you know, while I was doing my dissertation project. But I will say, to put in a plug for another project that I'm just beginning to start right now, and that's a digital history project where I am beginning to use the work of Vanessa Gamble and other historians, including myself, really, and map the this institutional network of Black established hospitals. And what I really like to do is to see, you know, sort of how this network sort of changes and evolves and you know, really begins to sort of decline in the 60s. I want to visualize that, and I hope that will become a teaching tool that I can release alongside my book, so that folks can see the extent to which, you know, African Americans really, you know, had to make a place for themselves, and particularly when it came to health and healthcare in the early 20th century.
That sounds like a fantastic project. I really look forward to seeing that evolve. All right, I'm going to bring in some questions from the audience. there's two comments from an audience member, Bernadette Pruitt, who I will make sure you see after the panel, because one of them is a very long description about some history in Houston that I think is directed to you, Dr. Sanford, but it looks like it gets cut off at the end. So I don't, if there's a question in there, maybe you can type it in again because it got cut off a little. But I know that this same audience member followed up also to ask Dr. Ighodaro and also to tell both of you how wonderful your work is and to thank you for it. But they wanted to ask, they said the structural inequities that Blacks experience daily in all areas of life, including healthcare, even for people with healthcare coverage, is painful. How do we get Black people to understand these disparities? Will we ever convince the world of these realities? Am I asking the wrong questions? And then there's a further discussion there, but I think I'll just open it up to both of you from that point.
That is a powerful question, because I am with that audience member 100%. It is exhausting, it's tiring, it's cultural taxation, having to not only, be in medicine, practice medicine, and then have to speak out against these injustices, and then also have to be a patient and experience some of these injustices. It's like, and then on top of that, experience other racial inequalities and injustices that we all experience as Black individuals living in America. It's like, how much more can we take? So what I have kept doing, and I think what keeps me sane, is I keep speaking out. I keep speaking out in a way that, I can get at audience members, get at the scientific community, get at the patients, get at public, because if we don't speak out, unfortunately, we have to be the ones to save ourselves. We're the victims, but we also, and history has shown this, the community activist leaders, Malcolm X, Martin Luther King, Angela Davis, Rosa Parks, we're the ones that have to speak out to save ourselves. And I think that's just what we're gonna have to do with this as well, and get more health activists. And I'm really proud and impressed that Rice is having this conversation right now, because this is part of the solution, is speaking out against it. And one thing I did personally is, in order to be able to speak out in a way that's authentic to myself, I went ahead and started a nonprofit, which is my Zigbee nonprofit. You can find more about it on my website. I think another thing that so my nonprofit is threefold. It's to empower the Black community with their healthcare, to educate the public at large about these health disparities, and to make change in the community. So I think one thing is we have to keep empowering each other and having these conversations, and I think teaching us, well, what are my rights as a patient? Do I have to stay at this hospital that has shown to gaslight me, to not treat me based on how I know I should be treated? And that's one thing that I'm wanting to work on with other collaborators and other physicians in the field, is writing blogs or writing pamphlets so that we can explain, here is the healthcare system as it stands, and here are your rights as a consumer of healthcare, whether you're Black or you're marginalized or you're white. But it's really focused for the Black community, because those are the people who need to hear this, so that next time someone like Dr. Moore feels that they're not being heard, or they're not being understood, or they're being dismissed, they can just up and leave and say, you don't have to take this. You don't have to sit here and continue to not be treated as human. You go somewhere else. And so I think empowering us and knowing what our rights are and what we can do as Black individuals, as consumers of this racist healthcare, I think that, is one step that we can all do together.
Yeah, and I just want to add on to that, to Dr. Ighodaro's wonderful comments, to just invite folks to dream, right, about what an equitable healthcare system looks like. I mean, really in line with calls for abolition in other areas of American society right now. We have to dream. We have to be able to innovate and to think through, how we can better ensure people's health, ensure that people are treated equitably inside of health institutions, and that, of course, people are not exposed to anything that could, negatively harm and impact their health. And I will say that's really, one of the reasons why I'm doing the work that I'm doing right now. I'm a person, I actually have a disability that I'm still trying to learn how to deal with. I deal with, blood pressure issues and watching, my sugar, right? And that, it's really interesting to be someone, now especially who, is versed in the history and much of the current literature, and yet still, right, also have to live this experience. And I tell you, it's super frustrating. I mean, it really is. I mean, to be able to access certain resources, to be able to demand respect. Maybe this is just me, but I make sure that I put, doctor or Ph.D. on any sort of health form, right? So regardless of how I'm looking, right, that I might be wearing jeans and a sweatshirt, but they know that I know, what's going on, right? And so I think, but again, that, much of my work and my activism is my scholarship, you know what I mean? And really sort of, trying to, sort of wield my power now as professor, right? And as someone who is engaged in the knowledge production process, to be able to contribute, some tools, some insight, something, such that we can keep pushing our system, and continue really, what I study in my book project, which is this pursuit of equitable and full citizenship, right, through, this side of health. It's been a long project, and we're still engaged in that. And my goal is to just learn as much as I can and be prepared, such that, in conversations like this, or even when I'm talking to, folks back home, my neighborhood, my family, right, that we all stay knowledgeable and engaged. And also, take control and make demands, right, of a system, that in many ways, I mean, has, doesn't have, our best interests always necessarily at heart.
And Dr. Stephen, I wanted to add to that about demanding. One thing that, in order for a system to improve, it must be accountable. And as of right now, hospital systems are accountable to who? Not to me, not to you, but to themselves. So anytime, a patient has a qualm, and this is across all hospitals, right? Anytime a patient has a qualm with how they were treated, you can call the hospital, they'll do an investigation, but that stays internally. So what if, instead of it being internal, they start putting that publicly, and healthcare administrators and the government starts demanding, Medicare, Medicaid, insurance companies start demanding, we need to see your patient, comments and start analyzing them among, okay, are more Black patients submitting more grievances against this hospital? Yes, no. And if they are, and they're not working to alleviate that, well, then I'm gonna stop paying you as Medicare, Medicaid, and I'm not, insurance. And then if Black individuals can start seeing these comments, oh, well, I'm not going to that hospital because they have a long history of mistreating Black people. I'm gonna go to that hospital because I know that when Black people go there, they get treated correctly. So I think that is something, I don't know how to go about doing it, but if that can be done, that will put fire under people, on the hospital administrators, to make drastic change. You'll see magic happen once you start putting that kind of data out and demanding for it. But as of right now, it's private. None of us have access to it. It's nowhere. And that's part of the problem.
Yeah, I just want to put a point on that too, and to say, well, two things. One, that healthcare organizations are also extremely powerful in state and federal legislatures. We've seen this in the case of Medicare and Medicaid when the AMA, among other organizations, did not support it. The National Medical Association actually did, right? Again, with the Affordable Care Act, these organizations did not support that, right? And even recently, there was a report that came out of North Carolina that talked about its nonprofit hospital systems and how they use unreimbursed care as a means to sort of champion their community benefit, right? It's often expressed in terms of dollars and cents. It's not like, sort of the more intangible forms of community engagement that I study in my work. But also that they still stick, working folks, folks who are poor, with the bills, with large bills, right? So even, hospitals themselves are also engaging in this project now of wealth inequality, right? And to enrich their own pockets. And this report, I was shocked to find, said that there was no organization to which these hospitals are accountable, right? To ensuring that they actually provide the charity care that they are supposed to. So I totally agree that again, sort of with the liberalization of the healthcare market, right? That we've also sort of lost the accountability mechanisms, at least with public hospitals. That the mayor or somebody in the city administration is controlling those institutions and that they are elected, right? And so, again, this is what I see in St. Louis. And so, if you are unsatisfied, you make your demands known in the political arena, right? And if it comes to it, you vote, right? And when we have sort of divested from these public institutions, and where there's a little sort of more degrees of separation between the consumer, the patient, and folks who are administering hospitals, and you get things like this, right, where they sort of run amok, where there's sort of not a lot of accountability, and where they sort of operate in a way that can exacerbate not just health inequalities, but again, economic inequality, right, social inequality, right, and we've seen that again in North Carolina. I mean, it was just absolutely egregious. On the levels to which they were, billing folks who, clearly could not afford to pay for those services.
I'm going to jump in here for a quick second because we're almost out of time, and I want to hand things back over to my co-moderator because I believe that she has a question. Nana, take it away.
Yes, sorry, I have a quick question. But first I wanted to start off by saying, Dr. Sanford, I truly agree with what you were saying about placing doctor before your name, because my dad has a PhD. He always makes sure to put doctor in front of his name before it in any formal papers, anything, just so that everyone knows what's going on, like you said. And Dr. Ighodaro, I also agree with what you were saying in your presentation. My sister has sickle cell, and she's actually told me about some of the experiences she's had in the hospital. So that really resonated with me as well. But I was just wondering, this is kind of more for Dr. Ighodaro, but if Dr. Sanford, you have something to say too, feel free. I was wondering if the disparities between races in healthcare are starting to be addressed in medical schools. Like, are they talking about it, or do we just continue to speak out in hopes that this starts to be discussed a little bit more? Yeah, that's
phenomenal question. And the answer is no. And it's been something that I think now that the medical field is like, oh my goodness, we are practicing race-based medicine. This is horrible. Now we're all like, everyone's just running around. We don't know what to do. Like, I think COVID just really opened up, it shined so many problems in medicine that now the medical field is scrambling. And so now the accreditation board that is responsible for accrediting different medical schools is starting to put out statements about, okay, this needs to, I don't think it's a requirement yet, but don't quote me on that, but they're starting to realize we don't teach health disparities curriculum at all in medical schools. We need to start teaching that, because if we don't, then this will continue to happen. So to answer your question, no, there's no formal teaching. And the only reason why I know about health disparities and do this work is because of my PhD work, and I had mentors who were able to challenge my thoughts that were instilled upon me in my classwork. But I am optimistic because I do see it across different medical schools and different training programs, and in my discussions with other residents and medical students, that it is starting to be discussed, but we don't even have a formal curriculum at many places. So it's starting to be discussed. At least we know it's a problem. It just, how long will it take before it's mandated, like biology is, or chemistry, or neuroanatomy?
And I just want to add really quickly that, my colleague Jaya Eseosa did an analysis of the medical curriculum at the University of Pennsylvania for the New England Journal of Medicine. She's found that, race is still, taught incorrectly. That, it's not made clear to medical students that sort of, biological difference, there aren't biological differences between the races, right? Now, we can talk about, again, some of the social manifestations of racism, and how that impacts, Black folks, but, it's still sort of taught incorrectly. There was a study in 2019 done by Hoffman, I believe her name was, where, medical students still had these antiquated, current day, 2000s medical students had antiquated understandings of racial difference. Really believing that Black folks had thicker skin, for example. In the 2000s, that somehow they are emerging from medical school with these kinds of ideas. And I agree with Dr. Ighodaro that, much more work needs to be done. And again, we really have to sort of take it apart and redo it, right? And a lot of medical schools sort of, kind of rely on the fact that medical education, particularly the coursework phase, is so busy, and, it's already set in stone. Well, then things are never going to change, right? If we just sort of rely on the status quo, right? So, but there's an abundance of literature out there that's beginning to critique, how race and racism and health disparities are taught, and we do need more of it. If we're going to be serious about this project of equitable healthcare.
And to even add more to that, our board questions, like all of us know, African-American female, 30-year-old shortness of breath, I'm thinking sickle cell, because that's what my system has taught me to think. So I'm looking forward, but you change one word, white American, my practice is completely different. And so it's embedded in our exams that determine, am I suitable to be an MD or not? So there's so much, it needs to be overhauled. I'm all about overhauling, deconstructing, and building it back together. So that's my solution.
I want to thank you so much. This has been so incredible, such a fantastic discussion. We were supposed to stop 5 minutes ago. I feel like we could go on for a long time. And in fact, I'm just going to mention, I'm not going to ask this as a question because we're over time, but I was going to ask you both to dream about if you could reimagine medical school, like what would that really look like top to bottom? So maybe that can be another conversation. And I want to thank all the audience members who posted questions. We're going to make sure they get to the panelists. I'm sorry we didn't get to answer all of them, but you touched on so many incredibly important issues. And I just really want to thank you both for your work and thank you for being here. This has been phenomenal. Thank you so much.